Well, welcome everybody. Just to echo what Carla's already said, welcome to this webinar hosted by the EAPC, focused on family caregiver research in palliative care, and the webinar is being hosted today by the EAPC Reference Group for Family Carers. So my name's Claire Gardner, and I'm Professor of Palliative Care at the University of Sheffield in the UK, and I'm joined today by my co-host Nick O'Donnell, who is Associate Professor at the University of Alabama at Birmingham in the US.
Good to see everybody. Thanks for joining.
Thanks, Nick. So just a quick overview of what we're going to be covering in the webinar today. Firstly, I'm going to give you a very short introduction to the reference group, the EAPC reference group, and just tell you a little bit about who we are and what we do. Then I'm going to hand over to Nick, who's going to tell you about state of the science in interventions for family carers. And then Nick's going to hand back to me, and I'm going to tell you about a piece of work that we did over the last couple of years as a reference group on strategies for designing and conducting research with family carers. And then at the end, we hope there'll be some time for a discussion with everybody. Oh, my slides have gone the wrong way there, excuse me. Sorry about this, my slides are skipping around slightly. So the EAPC Reference Group for Family Carers. So the reference group was established back in 2006, and the group was established by Peter Hudson, who's at the University of Melbourne in Australia, and he worked really, really hard in those early years and was very much the one who underpinned the development and the establishment of the reference group. Peter chaired the reference group for many years, and then I've taken over as chair with Nick as co-chair a couple of years ago. We've got these two strategic objectives as a reference group, which you can see here. Firstly, to promote the development of high quality research, and then secondly, to provide a platform for international networking and collaboration. So we have about over 100 registered members of the reference group now, and you can see there just some of the countries represented in our membership. It's a really international group. We have people from all over the world. Anybody who's interested in research, in family caregiving, in palliative and end-of-life care can join the reference group. It's free to join, and if you go onto the website of the EAPC, you can look at the website for our reference group, and then you can fill out a really short form which will allow you to join up and be a part of the reference group. If you join up, then you'll be added to our mailing list, and you'll have access to information about various activities and events that we offer as a reference group. Just to say, it is free to join the reference group, but you do need to be a member of the EAPC to be a member of the reference group as well. I just wanted to acknowledge as well our reference group management committee. We're very lucky to be supported by a group of real international experts in the field of family carer research in palliative and end-of-life care, and you can see a real list of experts here in the field. The management group works with us to support the kind of day-to-day activities of the reference group and help us deliver on our objectives. So as I've already said, we have a couple of kind of overarching strategic aims as a reference group, but then we also have specific objectives which guide our kind of activity on a day-to-day basis. And these are our current objectives. We developed these as a group a couple of years ago, and they were ratified by the EAPC, and these are the objectives that we're working towards at the moment. So firstly, we're working on updating the EAPC white paper on improving support for family carers, and that is building on work that was conducted by Sheila Payne and her colleagues back in 2010, and they published a white paper in 2010 in two parts which looked at improving support for carers. So we are updating that work now, which we hope to publish sort of the end of this year, early next year. Our second objective is around offering regular researcher development and dissemination programming focused on family carer research. So that's through events like this webinar today, but also different events and programming that we offer as part of other conferences and events. We typically try and host an open meeting at the EAPC conference every year. Unfortunately, there won't be one in Helsinki this year. As much as I would like to go along to Helsinki, neither Nick or I are able to attend this year. So sadly, there won't be an open meeting this year, but we very much hope to be back at the EAPC next year. And then our final objective is to support career development and research capacity building, very much focusing on early career researchers in family caregiving research. So that, I hope, gives you a little bit of an overview and an update as to what we are and who we are and what we're doing as a reference group. I'm going to hand over to Nick now to share your slides. Nick, and over to you.
Claire, can you see my slides?
Yep.
Okay, all right. Well, again, thank you so much, everyone, for joining. We've got a really nice crowd today. I'm going to start by talking about how far we've come globally in designing and testing interventions for family caregivers and carers in a palliative care context. Where are we and where are we going next? Let's see. Here are my disclosures. And so I don't think this is surprising, but just to kind of immerse into what the state of affairs is, the number and proportion of folks who care for someone with a serious illness is a very large population. And it's pretty fair to say that all people living will, in all likelihood, either be cared for by someone who's a family member or friend who will be doing that themselves for someone else, or they're going to need somebody in the future. And here you can just see a sort of a sampling of the population level statistics of caregivers in various countries. This is not every country, but you can see that we're talking about an extraordinarily large population of folks globally. If you're interested in learning more about this report, if you hover the camera of your smartphone over the QR code in the bottom, you can find the full report that goes over these population level statistics. So there's a lot of these folks. What are we doing to support these family caregivers? I'm going to talk about two things. First, where are we at with developing and testing interventions? And then two, what are the challenges that we face as researchers as we go forward in developing and testing new and innovative solutions? So to start with the state of the science, serious illness caregiving intervention development has typically been very disease-centered and or adult or pediatric specific. On the left, you will see diseases or population types, and on the right, you will see recent reviews of intervention trials with the number of trials in parentheses there. And there's nothing specific about any one citation that I think we should take away from this, other than to quickly note that there are some areas where we have done more and less work. So Alzheimer's and dementia has had the most work done when it comes to intervention development and testing, followed very closely by cancer and stroke, and perhaps heart disease. If you look at some of the other areas, you can see where we still have a lot of work to do when it comes to developing and testing interventions. If you have published a review in any of these areas and you do not see your name, please email me on the side. I will gladly add you to this table. Here is another report that reported it was a meta review of 61 systematic reviews focused on care interventions. It was focused on dementia, cancer, stroke, end-of-life interventions, and mental health. And one of the main conclusions, and I think a key take-home point, is that there really is no one-size-fits-all interventions to support carers, which is to say that all of the contexts that we think of, dementia, cancer, stroke, these are all unique in the way that they present themselves to families navigating challenges and the stresses that they face, the duration of their caregiving experience. They can all vary a lot between different types of serious illnesses for which they are caring for. So this is to say there really isn't one intervention solution that's going to really work for everybody. And I work in the oncology space. I work in cancer, and this is pretty consistent with the trends in many disease types. Each of these is a published randomized trial of interventions that have been tested in cancer. And what you can see is that over 5-year increments, the number of published randomized trials has grown exponentially, which is a good thing. I think that it shows that we've had an increased emphasis on developing and testing these kinds of interventions. So what do they look like? Well, they're kind of all over the place. I won't read any one of these in particular. You can kind of scan through. Most are psychoeducational. They tend to have a lot of contacts. The sessions, if there are sessions, or the encounter lengths can be anywhere from 20 to 3 hours long. Sometimes they involve the patient, sometimes they don't. Many are often led by nurses or other specialist healthcare providers. That might be a psychologist, a behavioral therapist, or other folks. You can see there what the intervention content tends to focus on. And then you can see the modality of delivery is most often either face-to-face or by telephone. So let me orient you to this table. This is asking the question, how effective are our interventions? On the left, you will see meta-analyses that have been published. Across the top, you will see outcomes that are caregiving focused. So you'll see caregiver quality of life, caregiver physical health, caregiver burden, anxiety, distress, depression, relationships. If you see a green number, that's an effect size, and green means good. So if you see a green, that means that the meta-analysis found that in total of all these intervention clinical trials, they found a significant effect size benefiting caregiving interventions. If you see NS, that means that they found a non-significant finding. If you see a dash, that means they didn't measure it. So I think without pointing out any one thing, you can see that in general, yeah, we've been pretty successful with developing and testing these interventions. We've had a good bit of success across a bunch of different outcome measures. Sometimes it's mixed results if you look at anxiety and distress or depression, but in general, we seem to be having some success in the development and testing of our interventions. So that might raise the question, well, if we take care of the caregiver, how well is that impacting the patient? This is the same structure of the table. You'll see meta-analyses on the left. Across the top, you'll see patient outcomes, patient quality of life, patient physical health, patient mental health, anxiety, depression, and symptoms. And again, here you can see that in general, we have had some success in being able to develop interventions that are focused on family caregivers that have a concomitant positive impact on patient outcomes. There are some places where we have mixed results for physical health, depression, and there are some areas where we still have work to do, such as in symptoms, where we've yet to have a meta-analysis that have really shown a consistently positive benefit of our caregiving interventions on patient symptoms. Okay, so we've got, it looks like, a lot of good interventions that have been developed and tested. I imagine that maybe some of you have active formal caregiving services that are provided in your clinical setting. And yet, at least I can speak for the states where we really don't. We don't have a structure that really supports robust, systematic caregiving support clinical services based on these interventions. So what have been the challenges? Well, first of all, not everyone's convinced that our RCTs of caregiving interventions have been of the highest quality. Many folks have critiqued the small sample sizes, the lack of interventions that are theoretically based, that there are high refusal and attrition rates. We approach a lot of caregivers, but not a large proportion are enrolling. We often recruit samples that are not distressed at baseline, which means that it doesn't really matter what we do. We're not going to make them any less distressed because they weren't distressed to begin with. Often we lack what's called minimally important clinical differences. We don't pre-specify how big of a difference we believe will be clinically meaningful for a particular outcome. A lot of these trials lack fidelity monitoring. So it's unclear if our interventions are being delivered as they were designed. We often don't have a lot of description of what the control group is or what usual care looks like at particular institutions. We often don't provide a whole lot of detail about the intervention itself. If you read an article that's published in a journal, I would guess that most of us would not be able to exactly replicate the intervention based on what we could read or have access to from that article. And finally, it's unclear or unreported whether or not the outcomes assessment was blinded or not, which is a very important aspect of ensuring that differences that we see are unbiased when we do our statistical analyses. So there's also been major challenges to actually implementing these cancer caregiving interventions. A lot of the reasons that I'm going to show I've really based largely on what I've seen here in the US. Clearly, that does not represent all of the folks that are present here, but maybe some of them do. First, we really lack data on healthcare utilization and cost, both of the caregivers themselves and of patients. When we do these clinical trials, this has not historically been an outcome that we have really collected or analyzed. And it's important because if we want these interventions to actually be implemented, they need to be set within a business model that fiscally, financially, we can sustain. And one of the ways we can do that is to demonstrate impact on utilization and cost outcomes. Often our interventions are limited to caregivers at one time point or a single setting. When caregivers obviously are not fixed at one time point, they are situated in time, and we often don't follow them longitudinally, and they are across all settings. The needs of families are varied and complex. What a family caregiver needs at diagnosis may be different when the person's at very end of life, and because of that may require more than one type of program or type of support. Interventions are often not tested in real-world delivery settings within existing payment structures. When we get research grants, we have lots of money to pay people and get people enrolled and make materials, but in the real world, those sorts of resources are often not present. At least here in the States, we have very limited ways to reimburse clinicians for direct support family caregivers. That's changing a little bit, but we still really lack a good way to reimburse for direct caregiving support. Another reason is that at least here in the US, we have a lot of scope of practice limitations with individuals who are, let's face it, they're not patients. We are legally liable for patients. We are not legally liable for folks who are family caregivers, and in fact could be in trouble if we start treating caregivers as we would if they were patients, if we're not seeing them, quote, as patients. So there can be some limitations to what we can actually do with folks who are not patients. There's often a lack of mechanisms to identify or refer families and close friends who could benefit. There's often a lack of an available workforce. If you go into your own healthcare institution and ask anyone you see, could they deliver an extra program? You may get the response of, I can't believe you're asking me that. I can barely do the work that I can for the patients I see. And then finally, at least here in the States, we find it actually, interestingly, very difficult to document information about caregivers in the medical record system here. There's a lot of legal challenges in documenting in a patient chart someone who is not the patient, and that includes information that could ostensibly be confidential and private to both parties. Okay. So, priority areas going forward to develop caregiving support. And I've drawn these from a lot of reviews and reports over time. One is to really test interventions that examine patient outcomes. So if we want to demonstrate that we should be formally supporting caregivers, it would probably behoove us to include patient outcomes, healthcare utilization, and cost in those trials. That we test interventions that are adaptive and tailored to the specific needs of the individual caregiver in front of us. To identify active ingredients of caregiving interventions There are particular types of trial designs called optimization trial designs that test individual components of multi-component interventions. We need to be testing these interventions with more under-resourced, minority, or at-risk populations, and consider extending into larger family networks. It's often not just one individual who's providing support to the patient, but a whole family and friend network that is doing so. Looking at interventions that have a longer duration over time, particularly in a palliative care setting. And that also goes across in and outpatient community-based settings. Interventions that leverage technology, which rapidly seems to change every day. And then finally, interventions that are tested under real-world conditions. So thank you. With that, I'll look forward to conversation and turn it over to Claire.
Excellent. Thank you, Nick. That was a really great overview. Really encouraging to see that growth in interventions, but still quite a few challenges to surmount, it sounds like. Okay. I'm just going to bring up my slides again. Okay. So I'm going to talk now about a piece of work that we have conducted as a reference group on strategies for designing and conducting palliative care research with family carers. And I just want to acknowledge Peter Hudson, who very much led this work and was the lead author on the paper. So thank you to Peter. Sorry, my slides are rather slow today. Carla, is there any advice you can offer? My slides don't seem to be... Oh, here we go. I'm hoping that's moved on to the slide saying role of family carers for everybody. Just before I go into the details of the study, I wanted to just give you a little bit of background, really, just to put the study into some sort of context. And firstly, just be clear about a definition of family carers, because of course there are many definitions. And I guess just to be really clear that when I say family carers, I'm not just referring to blood relatives, but actually anybody, any lay person who is in that close supportive role and who's sharing in the illness experience and undertaking that vital care work. Now, we know that in palliative and end-of-life care, family carers really are the foundation of the palliative care workforce. They are critically important in helping support patients at the end of life and deliver care. Estimates suggest they provide between 70 and 90% of all care at the end of life. So absolutely critical in terms of supporting our delivery of palliative and end-of-life care services. We also know that demand for family caregivers is increasing and likely to increase further. So you can see here a study which looked at projections for the number of people with palliative care needs over coming years. And you can see that although for the last kind of 20 years or so, numbers have remained relatively stable. When we look forward the next 20 years towards 2040, we are seeing significant rises in the number of people who are predicted to have palliative care needs. There's kind of various estimation techniques used as part of this study, so that's the various lines you can see. But whichever estimation technique we look at, the picture's pretty much the same. We're going to see big increases in the number of people with palliative care needs. Of course, in parallel to that, we will also see significantly increased demand for family carers who, of course, are providing the majority of care for patients with palliative care needs. Health and social care policy has also had a significant impact on the demand for carers, and I think across most high-income countries it's fair to say that there have been shifts in palliative care policy over recent years which have focused on relocating palliative care out of hospitals and into people's own homes and into communities. And of course, by and large, this is aligned with people's preferences. We know that most people would prefer to be cared for at home. When it comes to the end of life, most people have a preference to die in their own homes, and policy is aligning with that by trying to move palliative care out of hospitals and into our communities. However, By shifting palliative care out of hospitals and into communities, this of course has really profound implications for family carers who, as I've said, provide the vast majority of home-based palliative care. We know that carers are making a really significant contribution in terms of the time investment they are contributing to caring, and there's lots of evidence on this internationally. I've just selected a couple of key studies here. So firstly, a study from the UK, which showed that family carers were spending up to 70 hours a week on caregiving tasks, and then similarly a study from Canada, which found that during the last 4 months of life, family carers were spending almost 6,000 hours on unpaid caregiving. So carers are making a huge contribution in terms of their time investment, and that time, of course, has a monetary value to it as well, and an economic contribution. And the last study referenced here estimated that about a third of the total costs of palliative and end-of-life care are borne not by our NHS or by our formal healthcare systems, but actually by informal carers, and that represents many millions of pounds worth of time investment from carers. So in terms of characteristics of family carers and what family carers look like as a group across the world, I think it's fair to say that they're not a particularly homogenous population across the world, and carers have lots of varying individual characteristics. There are, however, some core common characteristics we tend to see across family carers of people with palliative and end-of-life care needs. We tend to see that the majority of family carers are female, so usually upwards of 55 to 60% of family carers are female. We also tend to see that most carers will be older, and most carers will be aged over 60 years, with quite a substantial proportion, potentially up to 25% or more, aged in the 80 years plus bracket, so certainly an older group. And then we also know that across the world, family caregiving comes with a considerable burden, and we know that family caregiving can be associated with a really wide range of negative impacts, from physical health implications, mental health implications, social, financial, employment implications. That concept of caregiver burden is pretty well defined now in the literature, and we know, sadly for many carers, it's a really challenging and a really difficult role. There are some positive aspects of caregiving as well, and those have certainly been identified in the literature, but I think the overwhelming picture is of burden for caregivers in this role. In terms of how many family carers there are, how many end-of-life family carers there isn't a huge amount of evidence on this. And I know Nick, in one of his slides, gave us some population estimates across the world of the number of carers across the world. When we look at the kind of subgroup of end-of-life carers, it's much more difficult to identify reliable data on this. And that's partly because we can only really know if somebody's been an end-of-life carer after they've stopped being an end-of-life carer. So they're quite a difficult population to identify, and that means there's kind of various methodological challenges with identifying it and kind of sizing up this population. But we did some research last year in the UK, and produced what I think are the first population estimates of the number of end-of-life family carers in the UK, and we estimate there are up to 750,000 end-of-life family carers in the UK, and we used some data from Health Survey for England, which is one of our national population data sets. 750,000 equates to over 1% of our population in the UK, and I think often we think of this group of people as being a small group of carers, a marginalised group certainly of carers, but actually when we look at the raw numbers, we're looking into the hundreds of thousands of people here. There's really quite a substantial number of people in our country living in this situation, providing care to somebody towards the end of their life. We also found from this study that of all carers, when we look at all carers, about 16% of all carers will go on to become end-of-life carers at some point in their future. So the person they're caring for who has a disability or a chronic illness, that will then progress to becoming an end-of-life condition. So I think a lot of what we know about family carers in the end-of-life context can also be applicable to that wider carer population, because we know, more than 1 in 10 of all carers are going to progress to become end-of-life carers at some point. So I've just given a bit of an overview of the evidence base there on family caregiving globally, and I guess have highlighted how important family caregivers are, but also really reinforce the need for research which focuses on family caregivers of people with palliative and end-of-life care needs. Family caregiver research has been identified as a core research priority internationally, and when we look at research prioritization exercises that have been conducted internationally, family carer research does tend to appear quite high on the agenda, and you can see a couple of examples here where family carer research has been rated first out of 32, fourth out of 10, and fifth out of 10 topics. These are all research priority exercises which have looked at priorities in palliative and end-of-life care research, and it's clear that family carer research is really rated very highly. So there's a strong policy, clinical, consumer and academic rationale for focusing on family carer research. We know how important family carers are in terms of care delivery, and we know they have significant support needs that aren't always met. So there's a clear need for further research in this area. We also know that research in palliative care can be really demanding, and we face numerous ethical and practical challenges when we're undertaking research in palliative care. There's a real lack of guidance and advice, however, which is specifically focused around family carer research, and it's that has underpinned this research study that we conducted as an EAPC reference group. So we conducted a study in response to all of these points that I've made, and the aim of our study was to develop and collate strategies for designing and conducting research with family carers of people with serious and life-limiting illness. So what we really wanted to do was to produce useful and practical recommendations and strategies to help researchers on the ground who are engaged in research with palliative care carers, and really help them throughout that research cycle. So the method we used was an expert elicitation methodology, and we used something called the IDEA framework, which is identify, discuss, estimate and aggregate. And that framework is really a way of aggregating evidence-based input from various stakeholders. So we asked experts to provide us with their views and their experiences, but very much based on their knowledge of the evidence. And we had 9 international experts who we worked with, and they each completed quite an extensive questionnaire broken down into these 3 key sections: preparing and designing research, conducting research, and then disseminating and implementing research. And then we worked together as a group to aggregate the results and build consensus around some recommendations and strategies for research. So I'm going to just move straight on to the findings. As I said, we kind of broke the study down into these 3 parts: preparation and design of research, conduct, and then dissemination. So I'm going to talk through each of those 3 sections in turn. So firstly, with regards to the preparation and design of research, we identified a range of strategies related to this, and they had really quite a wide scope, from supporting individual research practice all the way up to influencing national policy on research. So you can see here some of our recommendations focus on lobbying funding bodies, liaising with ethics committees, and promoting community awareness around family carer research. So I guess really trying to emphasise a top-down approach to influencing things like the availability of funding and also minimising gatekeeping. The other recommendations you can see here focus more on individual research practice, for example, promoting clarity around definitions. And obviously, when I started this presentation today, I started with a definition, and we really need to be very clearly grounding our research in that conceptual clarity to make sure we're being really clear and honest about the population that we're working with. And then the final point, and equally important, perhaps more important, is ensuring that we really involve family carers throughout the research process. And I don't mean here as research participants, but I actually mean as research partners, as collaborators and colleagues, and making sure that people who have lived experience of caregiving can contribute to our research, and their experiences can be central to our research practice. So next we looked at recommendations and strategies around the conduct of research. The first two recommendations here relate to the recruitment of carers and thinking about developing more flexible and more creative recruitment strategies, both to minimise the burden to carers, but also to maximise equity and diversity amongst our participant groups. Also important to consider is trying to make sure where we can that that equity is mirrored in our research teams as well as in our patient populations. It's also really important to make sure that carers are supported in their research journey, and as part of our research, making sure we develop protocols that can help us to do that. And you can see some examples there of how to do that: distress protocols, flexible data collection, etc. I think one of the biggest challenges we often face in carer research is, and I'm sure many of you have faced this challenge, is working with participants who we might label as a carer, but actually don't identify themselves with that term. Perhaps only would call themselves a husband or a wife or a friend or a neighbour, but wouldn't see themselves as a carer. So there's a lot of work, I think, to do with legitimising that carer role, which will help us improve recruitment of a really wide range of carers. I think that point also kind of links to this next point in green, and really recognising that carers offer much more than just proxy data for patients. Carers have their own very specific care needs, and it's important that we recognise those as being separate from the needs of the patients. And then the last point relates to another tricky issue that I think we often face in carer research, and that is how long after somebody has died is it acceptable to recruit a bereaved carer? I mean, there's no hard and fast rules on this, but I think we do need to challenge assumptions that we can't approach carers until many, many months after someone has died. We know that for some carers, they're happy to participate in research just a short time after they've been bereaved, and a shorter time can be acceptable. I think the important thing here is just to make sure there is sufficient justification for that. And again, working with people with lived experience, working with PPI colleagues can be really essential for providing that justification, and particularly for providing that justification to ethics boards. And then finally, dissemination and implementation of research. Again, some of these recommendations relate to how we influence funding and policy, and I guess making sure that we're really able to make a difference with our research and ultimately have impact on outcomes for carers. And we can achieve this by working alongside funding committees, but also working closely with others who are able to influence implementation. And certainly in a lot of our research in the UK, we work very closely with the charitable sector. They're often providing the front line of support for carers. So by working very closely with charities, we're able to make sure that our research can be translated into change and into benefits and into outcomes that will help support carers. As I've already said in this presentation, palliative and end-of-life care carers are a small subgroup of a much larger carer population. And actually, by working with the wider family carer research and advocacy community, we can potentially increase our influence outside of just palliative and end-of-life care. And then finally, and perhaps most importantly of all, again, involving carers in the preparation, delivery and dissemination of our research really is the best way to ensure our research will go on to meet the needs of that population. So we generated that list of strategies and recommendations. We've also taken that information and put it into a checklist for conducting research with family carers. I appreciate that's a little bit small to read on the screen there, but if you go to the publication, you can download the checklist from the publication. And we hope this will be a useful, practical tool for people embarking on research with family carers who can print this off and use this to guide their research practice. So just to finish off with some implications, some conclusions, we know that family caregiver research in palliative and end-of-life care is a high priority. Family carers are absolutely critical to service delivery. We need to make sure that they are adequately supported. Hopefully by developing these recommendations and strategies, we can drive up the consistency of research with around family caregiving, and can also increase the volume of methodologically rigorous and robust research. And just to finish by saying that research really needs to be engaging all stakeholders right from the top down. And I've mentioned a couple of times today, engaging with funding bodies, engaging with national ethics committees. And it's really important that we kind of widen the agenda for family caregiver research to make sure that we can have maximum impact. Final point, just to really emphasize again how important it is to work in partnership with those people who've got lived experience of family caregiving, and making sure that we're working closely with our PPI colleagues and family caregivers, and that really is the best way to conduct high quality research and make sure that we're having the maximum impact. Thank you very much. I will finish there and I'll stop sharing, and then we will have some time for questions. Okay, thank you. If you have any questions, please do pop them in the chat and Nick and I will do our best to answer them. So we've got one question here from Midrag. I apologise if I haven't pronounced your name correctly. In your research, did you notice any special needs of family caregivers under the age of 30? My professional experience is that this is a very vulnerable group of caregivers who can face many emotional, psychosomatic, social risks. Maybe some examples of good practice. That's a great question, and I think a really important population as we see a kind of growth in the community of people who are going to be called upon to provide care. We're certainly going to see more and more demand for young carers. It's not an area I'm a particular expert in. I'm afraid to say. Nick, have you got any thoughts on that?
If you're referring to sort of younger family caregivers who are sort of 20s, 30s, even younger 40s, they're usually caught up in a particular set of circumstances, which I've heard referred to as a sandwich situation, where they're caring for dependent children or younger children, and they're also caring for older parents, and they're also working. And that trifecta can really create particular strains in many ways. If it's for folks in their 20s who've sort of who are providing a lot of hours of caregiving support, it makes it difficult for them to progress in jobs or higher education. It can also take away time that they might otherwise use to socialize and, perhaps start a family or get married. I do not do particular research in that area. I know folks who do, and it's usually what I hear from them. And so I'm sure the solutions can be broad, from, different kinds of psychosocial support to financial to real sort of hard assistance. And I'm sure that would vary country to country just based on different policies.
Yeah, I mean, certainly from our research in the UK, whilst we haven't looked specifically at younger carers, we have done quite a bit of research looking at how caring affects employment. And of course, that's a much bigger issue for younger people. And we know that caring has a really substantial impact on people's employment. Often people will have to either give up work altogether, or if they don't do that, change jobs, change working practices. It's really, really challenging for carers to kind of juggle employment and caregiving. So I think that's a real challenge. I don't think we have good enough policy and certainly welfare policy to support younger carers either, especially those who are in employment. So in the UK, we've got something called carers allowance, which if you're providing more than 35 hours of care a week for somebody, you can apply for carers allowance. But if you're also in employment, then you're ineligible for carers allowance. So there's this real challenge, I think, for people who are juggling those two roles. The assumption is you're either employed or you're a caregiver. You can't be both. So I think that's a real challenge. Okay, and there was another question here from Juan Manuel. Thank you for your question. In Mexico, we don't really have a palliative care culture as a daily living culture. How can we improve the commitment and engagement of the population? Nick, any thoughts on that?
I think it depends on what you mean by the population. If you're referring to the clinical community, or are you referring to the engagement of patients and families, or are you sort of referring to sort of more governmental structures? I think the answer probably varies. My sense is that you can take a top-down approach where culture is sort of affected by policy, and you can kind of start by advocating to folks who influence policy or funding about the importance of supporting families in order to get the infrastructure in place to better provide support. Winning clinicians over, I have found, is not hard. It's making it feasible because they're already so busy taking care of patients. It can be difficult to provide an extra layer of support to families. If it's a palliative care issue, I usually just describe what we're doing. I don't have to use the words palliative care. I can just say we're offering additional support to families, and that is what we're doing. And that seems to do the trick. But I don't know, Claire, that's kind of how I took the question. What do you think?
Yeah, no, I think you're right. And I think there was a response saying they were referring to a general population. Yeah. I agree. I'm going to move on to the next one because we've got a few questions. Somebody, let me just check the name here. Bear with me. I'm doing research in family, end-of-life and bereavement support in specialised acute palliative care in a hospital setting. Recruitment of family members is very challenging for various reasons, legal, gatekeeping of healthcare professionals, etc. I'm under the impression that we mostly include family members who are coping quite well. Do you have any specific tips for recruitment of a more diverse sample? That's a question from Torsten. Thank you very much. Oh yeah, I mean, I absolutely relate to those challenges. And I think across the board, whether we're working with patients or whether we're working with carers, there is always that concern that we are recruiting the most well and the most able, it can be really challenging to recruit a more diverse sample. I mean, I think there's a number of things that we can do. A lot of it is about being clear what we mean by carers, and as I've already mentioned, being clear that when we talk about carers, that's a very broad term, and being very clear about the definitions, and also, you know, legitimizing that role and recognizing that it's not an easy role for everybody, and for some people it will be really, really challenging. I mean, I think as we've said, or as I've said in the presentation today, it's not just about how you conduct your research on the ground, but it's about having conversations with those further up the chain of command. And I know you've said in your question about gatekeeping with healthcare professionals and legal issues. So there are potentially conversations to be had with people like those ethics committees and with people who are in those positions of responsibility and who are able to influence gatekeeping, and thinking about that kind of top-down approach. I know that's probably quite a big ask, but I think we need to be thinking big about this, because it's not just about how we conduct our research on the ground, it's actually about those regulatory frameworks that surround our research and how limiting they can be. Do you want to add anything to that, Nick?
Yeah, I usually say with recruitment, especially when you don't look or sound like the population that you're recruiting, is to just start with the why you're doing this. People will participate in why you're doing something first before they will participate in what you're doing. So if you explain to them why you're doing this, we're doing this because we're trying to help make life better, less stressful, more organized, less, you know, where you feel like you're doing a great job caring for this person. And we have a program that we're trying to develop to help you do just that. Or we're doing a survey to learn more about how we're doing that, or interviews, or whatever it is. And start there so that people understand the cause that they're joining. And then you can describe the what. The way we're going to do this is doing interviews, or we're going to do a survey, or we're doing a trial. So I would try to start with the what, the why.
Great, thanks, Nick. So another question here from Shani. What's the experience of community volunteers as family caregiver support? Is this a sustainable option? I think that is such a great question. And interestingly, just before this webinar, I was in another presentation from a PhD student who's doing her PhD all about the role of volunteers in palliative and end-of-life care. And we were having just that conversation that I think certainly in the UK, there is a culture around volunteering that assumes that volunteers will just take on very basic, unskilled roles in supporting palliative and end-of-life care. They might work in a hospice delivering meals, or topping up supplies of gloves, or helping with decorations around the hospice. But actually, our volunteer community are a hugely skilled community with often highly educated, with relevant backgrounds that we could utilize. And I think there's huge potential for us to capitalize on that volunteer workforce to provide more support for family carers, but also even in care navigation roles themselves. And there have been some great examples internationally of volunteers acting in that care navigator role and supporting patients who perhaps don't have a family carer, supporting them throughout their illness trajectory. So I think there's a huge potential there. We probably do need to understand that how that could be operationalized a bit better. So potentially there's some more research, and obviously, considering the kind of regulatory frameworks that might sit around that as well. But I think that's certainly a huge area of potential. Nick?
No, nothing really to add. It's a huge area of my current work is to use what we call lay navigators, which are lay people who've received very brief training to deliver at least first line support. And I think that's probably the way to go from a workforce standpoint, because it's hard to ask nurses, physicians, other social workers to do more. So tapping into this, potential workforce, I think is a good facet to our interventions going forward.
Yeah, great, thank you. So a question from Emma in the UK. With the hoped for shift from hospital to community, not easy to answer, but do you have any thoughts on how the impacts, positive and negative, on family carers could be best investigated? And are there particular questions that you think should be prioritised? Yeah, I mean, a really, really good question. And it's really nice to see that you've put in there about there being positive and negative impacts on family carers. And I think that's definitely true. Certainly if we are moving palliative care out of hospitals into the community, there's certainly huge positives for family carers who are able to have the person they're caring for at home, but yeah, almost certainly negative implications as well. I think for me, one of the main implications for carers is a financial implication, and I think there's an assumption that when we move palliative care out of hospital and into our communities, that is associated with huge cost savings. And if you look at costs from a service perspective, from an NHS perspective, that is probably the case. It's a lot cheaper for the NHS to care for people in the community than it is in the hospital, but that cost is potentially just being shifted onto family carers. We know that about 15% of family carers of people at the end of life are living in poverty, and that shift out of hospital into communities is likely to really exacerbate that financial burden on carers. So for me, I think that's a really important question, and something that we need to be looking at, particularly in the UK. Nick, what have you got to say about that?
Yeah, I would agree. I think, Emma, if you're looking for outcomes to collect, I would be interested in out-of-pocket costs by families. I would look at time off work, other indicators of, caregiving time and effort that are expended from sort of a more economic standpoint. Because yeah, the health system saves money, but it doesn't mean money is saved, period. It means that the cost is simply reallocated onto families, as well as the effort and person hours that it takes to care for these people. So it's just shifting the work burden to these untrained families, in my opinion. So I would include economic indicators of what this is doing on the family's end.
Great, thank you. We're kind of coming towards the end, but we've just got a couple more questions here. Another question from Shani: how does gender impact the caregiving roles by immediate family? I mean, again, I think that's a really important question. We know most family caregivers of people at the end of life are female, but certainly, you know, huge numbers of men providing that care role as well. There are huge gender implications, I think, of caregiving, and not only gender implications, but I guess kind of intersectionality between other factors as well, and how they all join together. There was an excellent paper written a couple of years ago by Merin Gott on gender in palliative and end-of-life care, looking at some of those issues. I would definitely recommend you have a look at that if you're particularly interested in gender. Nick, anything else on that question?
In the US, we have something called the National Academy of Medicine, and they publish large reports. And one of the most recent reports was the impact of caregiving on women in academia. And I think that's a very good report that details at length the impacts that it has on women and their ability to advance, at least in academia, including like the hard sciences and stuff. So also applicable really across industries.
Yeah, great. Thank you. I completely agree. Another comment here from Louise: I think a lot of people who find themselves supporting someone at end of life at home are surprised and shocked at how much is involved, and realise that there is not as much wraparound health and social care support as they thought, and need much more support in navigating the health and social care systems. Yeah, gosh, I absolutely agree with that. That's so true. And I think, again, you know, going back to that previous question about what needs to be in place if we are moving palliative care out of hospitals and into our communities, that wraparound care, making sure out of hours care is in place, is absolutely crucial to enable people to be cared for at home. As you've very eloquently put there, you know, the burden really does fall to family caregivers. They need to be properly supported in that role in order for, you know, for patients to have the best outcomes.
Yeah, I would just add that often we have this ideal in palliative care that it's ideal if people die at home, but I'm not sure that's always the case, that that's ideal. It's a lot of work to care for a dying person in the home, especially when you're untrained. And not to mention that it can be a little traumatic for someone after the death of the person to know that, you know, their loved one, maybe their spouse, died in this bedroom, and that's what they think about when they now walk into their home. And so I would just say that it's probably for many people, it may not be for everybody. And just, I think more thought has to be given around the pros and cons of where someone dies and the work that it takes and how it's going to be done.
Yeah, absolutely. Okay, I'm just going to finish with one more question because we're nearly out of time, from Vilma. Caregivers to children with disabilities are usually excluded from even the definition of caregivers, as they are parents who are expected to care for their kids, ignoring the burnout that they can experience and how that impedes them to perform the other roles they're expected to fulfill: work, caring, etc., especially for women. What do you think? Yeah, I mean, what can I say, but I agree, and I think this goes back to you know, what we were saying about conceptual clarity and who is a caregiver and what is a caregiver. And I think there are some people who we might consider to be caregivers who don't see themselves as a caregiver, and then on the flip side there are people who do perceive themselves to be caregivers, but as you said, aren't, you know, don't necessarily fit under that label under certain circumstances. So yeah, that conceptual clarity is really, really important, I think. Nick, any final thoughts on that?
I agree with that. It makes it very difficult from a policy standpoint too, when it's difficult to define who a caregiver is, and then how policies should thereupon apply. It's challenging.
Yeah, absolutely. I can see we've got a few more questions which I haven't got time to answer. I'm really sorry about that, but it's great that we've had so much interest and so much discussion. It's clear to see that people feel this is a really important topic. So thank you for your engagement. It's been really nice to see how much interest there's been. As Carla said, the slides, the recording will be available on the EAPC YouTube channel, so you should be able to access it there. And then just a reminder that if you want to know more about our reference group, you can have a look on the EAPC website. But thank you very much for joining us all today, and have a nice rest of your day or evening or morning or whatever, whenever it is in the world, wherever you are.
Thanks for coming, everyone. It's great to see everyone.
Thanks. Goodbye.